We have a 67-year-old lady who presented with pancreatitis in April 2012. At that time, ultrasound showed a 9 centimeter cystic lesion in pancreatic body and tail. Serial CT and EUS showed the pancreatic cystic lesion had decreased in size initially down to 4 to 5 centimeter, and then subsequently increased to around 6 centimeter. The cystic fluid amylase level was around 16,000. The latest CT showed there's a unilocular cystic lesion now measuring 6 times 5 centimeter and pancreatic head region. This is the pancreatic pseudocyst of this patient. We are going to perform a EUS guided drainage for this patient today.
Hello, good afternoon. Our patient is having a little bit of a respiratory issue during the procedure, so we took out the scope. But we just want to let you know that we went down to the duodenum and saw a pseudocyst about 5.5 centimeter by about 4 centimeter measurement, and that's actually quite close. And then when we went back to the stomach, during that time we have to stop the procedure, but it looks like there was actually a fair amount of pancreatic tissue anteriorly, and that the pseudocyst is lying posteriorly. So that's maybe a little bit tricky in the transgastric approach. So we may have to do a transduodenal approach depending on how things are.
Yes.
We also talked about the possibility to drain through transpapillary approach. So we'll see how it goes. And yes. I think that we probably need to do a ERCP anyway because it has to be an intrahepatic duct.
Yes.
That's why it's been persisting for 3 years. So it may not be a bad idea to do a ERCP approach. We'll see how it looks. But I think that for now we probably have to go to another room so that we can.
Ready.
Oh, she's ready for us again? Okay.
I think when we were reviewing the case history, so Simon and I also talked to a patient about the possibility of a ERCP because just based on the recent CT images, so there may be a need for ERCP to look at the pancreatic duct and to consider transpapillary drainage.
Okay, so again we are back into the stomach, and the patient is still coughing a little bit, and so we'll see what we have. So I just want to, I think this is the part of the pseudocyst. Now it's very quickly, I lost that. No, this is not actually, so the anechoic fluid on the back of the pancreas, you can see that, right?
Yes, we can see that.
Yeah, so I'm trying to go to the tail and pulling back the scope and going to the tail, and I'm still not seeing a good, this is probably, that's it. Now, there's a small window. Now, it actually connects all the way to the head of the pancreas if you go by the CT scan. So let's see what the distance is. If we were to puncture here, can you mark the?
Yes. You want to go back to?
Let's see. And so I think it is not a very good window here. Very small, very short. Very small. And so, what do you think? Who is in the on the panel right now?
Yeah, Simon, this is JV here.
Hi. So, what do you think? Now, let me see if we can freeze. Okay, we freeze that and make sure the distance. So from here to here, that's like almost 1.5 centimeter. So okay. I'm not totally happy about the distance.
But that's somewhere in the stomach of the duodenum, Simon, no?
Right. The transduodenal is much better. Oh, that's a little bit better.
Yeah, this looks like a better window here.
From here to, so it's like 8 millimeter.
Yes.
Now, although there's some kind of junky things in here, although generally that's okay. What do you think? Should we go the transduodenal approach, transpapillary approach, or transgastric approach to the tail?
So the distance is quite a bit, Simon. Actually, even I'm slightly concerned. I think maybe you should try a transpapillary approach.
I'm sorry, what about the transpapillary approach? So, what do you think? Raymond, I can do anything now. The transpapillary approach, the problem is sometimes when the pseudocyst is large, the small 7 French stent may not do that well. The advantage is that we get the idea about what the duct look like. So there's plus and minuses.
Yes, I think a transgastric approach like here looks like a pretty safe window.
Okay, all right, so we should do it this way?
Yes.
You're the host, so I'll do whatever.
Okay.
Okay.
Well, we also plan to put in a covered metal stent, a specially designed stent for drainage of fluid collections, which is the Nagi stent. So looks like this could be a better position here.
Okay, so, all right, so what we're going to use is a 19 gauge needle.
Simon, there is some amount of debris in that, and I think you putting in a
there are debris
plastic
here,
stent
right.
would be okay with this patient. Putting in a plastic stent would be okay. I think you have to put a metallic stent, like because
Well,
there's some
we are going
amount
to
of
do is
debris.
metallic stent,
Okay.
correct.
Okay.
Yeah.
So
Thank you.
If we have the external view, this is the metallic stand that we would like to use.
This
Okay.
is a
So this
19.
is NIC TS, a specially designed stand for drainage of fluid collection. It's a lumen opposing stand, and but it may or may not be as a lumen opposing as like the axial stand. So, but in this case, since we are concerned
can you
about
help me
debris,
hold the scope?
so we think this stand with
Two hands,
caliber
two
of 1.5 centimeter diameter
No,
could be
one
a
here,
good
one
choice,
there. Yeah.
and
More
we
stable,
can
right.
actually do endoscopy
Are you
through
okay?
the stand to clear up any debris if necessary.
Yeah, that's a very good indication because this stent has got a slightly larger caliber or diameter, so that subsequently if you have to go in and do some necrosectomy, I think you should be able to do it very easily.
Yes.
So now I'm using a 19 gauge needle, and I'm going to deliver a 0.025 guide wire. Now you can see that usually I prefer to point the needle vertically downward so that it won't push the tissue away as you go tangentially. Unfortunately, these large caliber needles don't bend that well. You saw me kind of bending a little bit if you saw that in the room earlier, but it still doesn't do that well. So it is what it is. We're just going to see what we can do here. Now, I first check if there's any vessels around. I don't see that. So we're okay this way. All right, so the needle is in. Now, so the first thing I usually do is to collect some fluid.
Yes.
And so our assistant is going to pull the needle, right? Pull the needle and then collect some fluid first. And then we will deliver the guide wire. Yeah, please.
Okay.
Very clear fluid. What do you think? Nagi, can you see the fluid?
Can we zoom
Can we
to
zoom
the
in
syringe?
yes.
Oh,
Could you
it's
keep pulling? Yeah, yeah.
clear yellow fluid.
Yes. A little cloudy.
Okay.
A little cloudy,
A
oh,
little
yeah.
debris that we saw.
Oh, wait,
I'll show it to you. Yes, that's true.
okay, can you see?
Yes.
Well, we don't want to collapse too much.
Okay.
Yeah.
Okay.
Yeah.
So,
So what do you think of this? Now, the usual pseudocyst fluid is rusty, kind of brownish color. Now, this one is probably because it's been so long. I don't know if there's any doubt that there's pseudocyst, but we're going to send the fluid for cytology,
Sure.
for amylase,
yes.
and for CEA. Okay?
Okay.
Yeah. All right.
So, Simon, is there any role of contrast injection during this type of drainage procedure?
There is, but that is probably okay when you put a guide wire. As you know, we usually put a guide wire, loop it quite a bit.
Okay.
Yeah, multiple. Yeah, go ahead. So we'll use fluoro. Okay, Vance. Keep going. Keep going. Yeah, keep going. Keep going. Keep going. There's some resistance, but okay now, right? Keep going. Okay. Now, so keep going. I usually do like 2 or 3 circles. Okay. So this way allows you to tell how large the cyst is.
Yeah, this
Okay.
is one way to measure the diameter of the cyst also
Right,
actually.
right.
Yeah, between the
Okay, all right,
points,
that's
actually.
fine. All right, now we're going to, so change this advance. First, I'm going to back up the needle, and then I'm going to slowly pull, and I'll use the X-ray to help me. Could you push a little bit more first?
So
Okay, that's it. Okay, keep going. Keep going. Keep going. Now, if you look at the ultrasound, it's like a little bit tangential here. So we have to be careful. This like 025 guide wire now. So we're using that to allow the cystotome, which is a 6 French, to go in. But the disadvantage is that the guide wire is a little bit soft, so it doesn't keep it in the direction we want as well. So it's quite tangential, so we have to be careful, okay? By the way, what size scope is it? There's a T ultrasound scope, so there's a 3.7 channel.
yes.
And so that's the only one that we can use. If we use the smaller 2A channel, it's a real problem to do anything. Okay, so we're backing it up, and there's nothing to rush at this point because it's really important that we don't lose access, and the scope had to be hugged against the gastric wall in order for it not to be. That's part of the U.S. problem, is that it kind of easy to it not have the same orientation the ERCP scope, so it's very easy to lose your orientation. So. All right, now we have the cystotome going in. So I'm keeping my eye on the guide wire by ultrasound just to be sure, and keeping one eye also on the X-ray.
So
As I'm pushing, I have to make sure that I'm not pushing the guide wire outside the stomach or the cyst. So I'm keeping everything straight. It's very, very important to do that. You can see already, if you look at this, that the distance now is from here to here. That's already 18 millimeters. So that's one of the problem of this thick needle to use to puncture. So we better hope that this cystotome performs well for us, because the more force we're going to push, the more likely it's going to separate the tissues.
this is really like the key step in the process.
Now I'm elevating the tip of the endoscope as far up as possible to kind of keep, and also the elevator as well to go up as much as I can, to hug against the area so that shorten the distance. So you see the instrument coming out now. Let's see, okay, right here. All right. All right. What do you think, Raymond?
Well, I think now we got a view of the
Can we have the
cystotome and the
fluoroscopy
wire.
image
I
also,
think
please?
looks
Yeah.
pretty good.
Yeah, right here. So we're still in a pretty good angle. We use the yellow or blue?
The blue.
Blue, okay.
The yellow?
Are you ready?
Yellow.
Oh, yellow.
Okay, yeah, let's do it yellow.
Okay, I shouldn't trust you all the time.
Oh, yeah.
Okay. It's going in really well. Let's see. Okay,
Yeah,
just
yes.
a little bit more. Okay, we are pretty far in now.
Yes.
Okay.
Running
Yeah,
smoothly.
right.
Yeah, all right. So now we're going to exchange the this for the
But the
stent.
dilation, we need actually to dilate the track a little
Okay,
bit.
all right, okay. So now we're going to exchange again.
So
Aye.
what we just performed, what Simon just performed was cautery dilation with a 6 French cystotome. And we're going to use dilating balloon, hurricane balloon, 4 centimeter long, 4 millimeter in diameter. And this will help us to make it easier for us to insert the Nagi stent, which has a delivery catheter of about 8.5 French.
So GV, the fluid that we got out didn't have much of any
It
debris.
looks
as
slightly
you
turbid, Simon. Actually, it
saw.
looks
A little
like-
turbid,
yeah,
but
it
it's
looks
not
like-
too cloudy.
Yeah, it looks slightly turbid.
Actually, let me correct myself. The delivery catheter for the Nagi stent is 10 French.
Now, in the US, we don't have the smaller caliber cystotome. It's only 10 French.
Yes.
So for us, we just go straight with the stent.
Without the need
Yeah,
for the
yeah,
balloon dilation.
right.
That's right. That's right.
Yeah, that avoids one exchange of the guide wire.
So you see the guide wire is still pretty secure in the
Yes,
in the
yes.
cyst.
Yes, Simon.
Okay. And my assistants are outstanding. So one is holding the scope for me so that I can have a very steady view. Another one is putting all kinds of things in front of my hands so I don't have to do anything.
So you're not doing anything. Only the assistants are doing the procedure.
Of course. Okay, now so you saw the dilating balloon with the 2 black dots. And so we're going to put it right inside first. I usually like to put contrast in there. Do you have the contrast? Okay, good. So let's go ahead and dilate it first. Now I may be too deep in, but I want to dilate further in first before I do that. Okay, go ahead. Okay.
So Simon, so how important it is during the dilation? Do you use the luminal view? Do you use the X-ray? Or what?
X-ray is better because I think you can see the waistline.
Position right?
So and again, I'm a little worried about using this scope. Like if we have separation, you may lose the access.
Yes.
Yeah. So blow up all the way. Is a max?
No, it's max now.
Okay. All right. So it's pretty easy. So deflate and let me go. You can see it on the EUS as well. See the balloon.
Yeah, beautiful
Yeah.
images,
Okay.
Simon.
So I
actually.
think that we need to go back up a little more. Okay. Deflate. Okay, let's dilate again. Yeah, balloon up. Yeah, okay, good. All right, so I think we're good. Okay, it's now. I'm not familiar with this particular stent, so I'm going to defer to Raymond, and I think it's only fair to the patient and the audience that he does it since he does it normally. Is that okay, GV? Or
Yeah, that's
Okay.
absolutely fine,
Yeah.
Simon. That's so nice of you.
Yeah. Now this is a wire-guided kind of what do you call that short wire system, so that Raymond is holding the guide wire externally so that he's not losing any access while he's pulling out the balloon.
Okay.
So now is the critical part is that they're exchanging externally.
So Simon, do you always use cautery when you do the tract dilation?
But Simon, do you think pure endosono deployment is okay with this kind of procedures, or you think additional fluoroscopy is mandatory?
I like fluoroscopy. Just give me extra secure feeling. I certainly don't typically do it without, so I have to say that I like it that way.
Okay.
How about you?
I mean, yeah, what you said is right. Actually, fluoroscopy. Suppose you have this contrast enhanced EOs that you're talking about now. That comes in. You think you can avoid fluoroscopy then?
Possibly, yeah. I mean, there are a lot of people who do it without, and it's more a comfort level. If you're used to doing that, then it's not a big deal.
Okay.
Okay, so now I have the stent. I'm inserting the stent into the scope channel, and we're trying to maintain visualization of the wire on both the EOS and the fluoroscopy.
You know, it's very interesting when we do pseudocyst drainage. if all goes well, it's very easy.
Yeah, right.
And the trouble is that one single thing that is misstep, it can be a problem. So it is when the X-ray become helpful.
Yeah,
So
absolutely
now
right.
I'm inserting the stent.
Okay.
Beautiful.
Yes, and on X-ray we have a view of the stent.
Yeah, you
Okay.
can see that both EUS and fluoroscopy.
So now I may require a little bit of the endo view now. So I'm going to.
You want to swap?
Yes, we'll swap. No. So. Okay.
Everything's frozen, isn't it?
Yes. Let me see. Okay. No, let me see. Okay. I'm getting the. Okay. I'm trying to get some of the lumen view here. You know, I think what I'll do here, I'm trying to keep the luminal view small and then keep the ultrasound view, and as I try to get a luminal view here.
You need to pull back.
Yes.
Yeah,
Okay,
yeah.
yeah.
You can see it, right?
Now I'm getting a better view here. Okay.
Okay.
So, no, we're seeing this then. I feel like I'm quite far in.
Yeah, I think it's too deep into the thing now.
Now see how close it is to the G junction.
Now I feel some resistance. Can you give me some tension on the wire? No, I'll pull back a little.
You're pretty far already.
Yeah. No, okay, here I see the end of it. Okay. So let's hold it. Here.
Okay.
Okay. Now, okay. Let's slowly deploy. Okay, slowly deploying.
Can we see on X-ray?
The end also.
Oh, she's waking up.
Okay,
Yeah.
can we get some more medicine?
Actually, these stents are visible beautifully even on the US images actually.
Yeah, I'm okay.
Deploy. Okay, keep going. Keep going. Slowly.
Can the audience see the flaring of the stents?
Yes, we are able to see it very clearly.
Yeah.
Yes, deploy. Okay, hold, let's hold.
Okay, I'm pushing it a little bit. Okay.
Okay, now keep deploying. Okay, now keep deploying. Now I may now I have to pull back a little bit. Now I may have to adjust the scope a little bit. Okay, let's hold it here. Okay, deploy.
Give it some air, yeah.
Okay, deploy. Okay, up. Okay, deploy. Up, deploy. Okay, deploy.
Okay. Great.
Oh, great.
Excellent, Raymond.
Okay, thank you, Raymond and Dr. Low.